So at this ASH meeting, I'm chairing the education program, and my speech in that section is on how do we sequence novel agent-based therapies in chronic lymphocytic leukemia. This is a challenging topic because we have many new drugs available to us, and we only have limited prospective data now on which order of administration is optimal for patients. So in general, I think a helpful way to think about this is to first look at the TP53 status of the patient. Do they have a mutation in TP53 or deletion 17p, in which case we'd consider this to be TP53 dysfunction. We know those patients do not typically have durable benefits with chemoimmunotherapy, and so we typically now would start with an ibrutinib regimen, usually ibrutinib monotherapy for these patients, followed by, in the relapsed refractory setting, venetoclax, where we have prospective data suggesting about 2/3 of patients will have a good response to venetoclax after progressing on ibrutinib. The other group is patients without TP53 dysfunction, and there it becomes a little more challenging. We have to think about the age and comorbidities of the patient. We have to think about other factors like patient preference in terms of oral therapies versus IV, and other factors such as the mutation status of IGHV. So for that group, if they have mutated IGHV, lower risk disease, we typically do recommend starting with chemoimmunotherapy, either FCR in the young fit patients or BR in older, frailer patients. If they have unmutated IGHV, it's still very reasonable to use a chemoimmunotherapy-based approach. However, it's also reasonable to consider ibrutinib as a frontline therapy for these patients. Once patients progress, it depends on what they got in the frontline setting in terms of what you'd use next. If they've received chemoimmunotherapy, most patients are getting ibrutinib as their next line of therapy, but venetoclax and idelalisib with rituximab are also good options there. If they've previously had ibrutinib, then as I mentioned before, the best prospective data we have now is for venetoclax in that setting, where about 2/3 of patients will have a response. So that's, in a nutshell, how we're thinking about sequencing therapy in CLL today, but it's a challenging area, and it's one that we need much more data on to guide us.